Hello and welcome to today's webinar. I'm Jim Rosenberger, Director of the National Institute of Statistical Sciences, and I'm pleased that NISS can host this 14th scheduled webinar in our joint COPSS-NISS series on COVID-19 related data science. COPSS is the Committee of Presidents of Statistical Societies. I again thank Professor Shihong Lin, Chair of the Organizing Committee, and all who helped organize this series of webinars. Thanks to Glenn Johnson of NISS and Lingxiao Xu, Associate Professor at Penn State and Associate Director of NISS, who provide technical and communication support for the series. The 15th webinar is scheduled for 2 weeks from today, and it will be at 4 p.m. Eastern Time rather than the usual time at noon. Information is available on our website. Participants are all muted, so we encourage you to put your questions during the discussion into the Q&A box at the bottom of your Zoom screen. Today's webinar was organized by Professors Elizabeth Stewart and Karen Banding Roche from Johns Hopkins University, both members of the organizing committee. And the webinar today will be moderated by Ryan Tibshirani from Carnegie Mellon University. Professor Ryan Tibshirani will now introduce our speakers. And I turn it over to you, Ryan. Thank you.
Thanks, Jim. My pleasure to introduce today's two speakers, Frauke Kreuter and Alex Reinhardt. Frauke is leading the global arm of the survey initiative that is newly named COPSS-NISS, the COVID Tracking and Impact Survey. Make sure I got the acronym right because it's the first time I'm saying it out loud. And Alex Reinhardt is leading the US arm of COPSS-NISS. So I'll just give them a brief introduction and then I'll ask them to take it away. So Frauke is a professor of statistics and data science for the social sciences and humanities, both at the University of Munich, and a professor in the joint program in the survey methodology at University of Maryland. Frauke co-founded and co-directs the data science centers at the University of Maryland and Mannheim. She's done a lot of work at the interface of statistics, survey, and policy. And this is one of the latest ways in which she's having a big impact. And she was awarded just this last year the Warren Mitofsky Innovators Award of the American Association for Public Opinion Research for what I believe is a recognition for the work she's done over the course of her career. Alex is an assistant teaching professor in statistics and data science at Carnegie Mellon University. He works on statistical models to understand and predict where events occur. And most recently, I abducted him from his maybe more calm life doing such research and asked him to join Delphi. And he's done an amazing job over the last year leading the survey efforts, like I said, from within Delphi. So I could not be more pleased to introduce the two of them and to hear about what they have to say about this incredible survey. Please take it away.
Great, thanks Ryan for the introduction. I'm going to start us off here with some methodological backgrounds on COPSS, and we'll then turn it over to Alex with like a quick prompt on next slide. So he's the slide driver. We'll have about 10 minutes sort of on the methods part before we dive into the vaccine hesitancy that you're all waiting on. Ryan mentioned that the two of us leading these two arms, the global part and the US part, but there's an army of people helping us to do that. And it spreads actually across both Carnegie Mellon University, the University of Maryland, but also Johns Hopkins University was pretty heavily involved in some of the analytics and questionnaire design around mental health. Elizabeth Stewart, one of the co-organizers of the seminar, for example. The survey was partly actually initiated by Josh Solomon from Stanford University and Elizabeth Belinsky from Harvard University. They approached, like many other researchers, and I think Ryan, you were one of those too, the Delphi group, approached Facebook early on during the pandemic to see if data collection could be done using Facebook as a platform. And for that reason, we have a whole bunch of people, in particular, Sarah Lauker, Catherine Morris, and Esther Kim from Facebook working on this survey. Next slide. So as I mentioned, there were a set of researchers early on in the pandemic that approached Facebook to see if it would be possible to start a syndromic surveillance survey, a way to ask a lot of people quickly if they experience any symptoms, so that forecasting models could inform policymakers and drive the decisions on where resources should be put before testing numbers or hospital admissions give an indication where the next uprise or hotspot of the pandemic would be. And the idea was that Facebook can reach a large segment of the population, certainly not the entire population, but in particular in the US, the number of people on the Facebook platform is pretty high. And also globally, a large fraction of the populations are on the Facebook platform. And so the idea was to use that technical infrastructure to field surveys to people on a daily basis, random subsamples on a daily basis, to ask these symptom surveys and help with the forecasting. This COVID tracking and impact survey, COPSS-NISS, was created after these early discussions in April 2020 and has run since then on a daily basis. I should mention that, like any data collection attempt, and any one of you ever designed a survey knows, as soon as you have something in the fields, a lot of other interest groups pop up. And so WHO and World Bank and many other players chimed in with questions, and we're now in wave 11 of this instrument. We have been changing questions as needed as the pandemic evolved and as we saw things are relevant. And the vaccine module that we are going to introduce today is one of the newer additions to this early syndromic survey. Next slide. Okay, next slide. Let me give you an insight into the project structure. Facebook invites on their platform anyone who visits the news feed to participate in the survey. And I shouldn't say anyone, because it is actually not anyone. It is a random subsample that is drawn based on a selection mechanism that follows statistical principles, meaning there's a probability sampling scheme going on by country, stratified by region, so that we have a good representation of the geographic areas of interest. And only those users of the Facebook platform that are invited to participate can take this survey. Once they hit on agree to take the survey, there's a little bit of consent and information listed on that Facebook platform. But once they say, yes, I'm interested, they get transported over to a web survey platform called Qualtrics that is hosted for the US at CMU and for the global part at the University of Maryland. On that web survey platform, people answer the survey questions just like they would any web survey, and the data are stored and remain with the two respective universities. This creates a big wall between Facebook and the actual survey answers, and has the advantage that we are able to share the results both in an aggregate fashion via an API from both of the university websites, but also the microdata for research, further research with academic analysts. And we will talk about the data sharing part at the end. The other cool thing about the survey setup is that we exchange with Facebook a token that basically indicates to Facebook only who responded and who didn't of those invited. And that allows them to give us a weight so that we can reweight the data so that they represent those that were invited but choose not to participate, and some post-ratification adjustment I will talk about in a moment. Next slide. Some of you might have seen these kind of invitations to our survey when you visit your own newsfeed, but you might also have come across other invitations for a survey on the Facebook platform. Most of those that you see are different than what we do. It has become, I wouldn't say common strategy yet, but a newish strategy to field paid advertisement on the Facebook platform and invite people to take a survey that way. That's not what we do. Those paid advertisements, they get distributed via an algorithm and are somewhat black boxes. We don't have that setup. We are at the top of the news feed, and the sample selection is controlled through the sampling scheme. Next slide. So let's move on to the instrument. The survey itself is translated in over 50 languages. In the US, I believe we field 5 or 6 different languages, and worldwide, a little over 50. We, once in a while get emails from users suggesting they could translate in yet another language that has been missing. But in terms of content, the survey has 5 main sections. Clearly a consent section that's quite elaborate for those members of EU countries following the General Data Protection Regulation. Then the aforementioned syndromic surveillance questions on health symptoms, and for the US at least, some pre-existing conditions. A large section on social interaction, social distancing, that was of interest, particularly early in the pandemic. A section on mental health, economic insecurities, and this newer module that I mentioned before on vaccination. And then a set of demographic characteristics. Those are more detailed for the US than they are globally. It's a little easier for us in the US to know what to ask there. For example, race, ethnicity, doing that differently for each of the countries would be very hard to program. But in the US, where the survey runs at an even smaller geographic level, those have been quite useful, and we share the results later on by those demographic subgroups. Next slide. Since April of last year, we had in the US over 20 million respondents, and globally, not including the US, another 52 million that completed the survey since its launch. And this is the case for over 200 countries and territories worldwide where Facebook is allowed to operate. And for 114, we have survey weights so that we get a little closer to the target population. Next slide. I mentioned weights before, mostly in terms of non-response weights, but want to explain just briefly, and we can come back to this in the Q&A. There are 2 sets of weights that we get from Facebook. One is a weight that represents all the people that Facebook invited, but chose not to participate. And to do that, Facebook uses data from its own platform and looks sort of how similar are those, that were invited and didn't participate to some of those that participated, and then upweights the answers of those that participated to make up for those that we lost, right? And we use, for the nerds among you that know how this works, inverse probability weighting schemes to do that. So we predict the probability to participate in the survey and then use the inverse to that. There's a little bit of weight trimming going on, but not too much. On top of that, we use post-stratification so that we can adjust the basic demographics somewhat to the numbers that we have on a region 1 level, so states in the US, using data as benchmark from the US American Community Survey and globally on the UN Population Division. I should mention that anyone who's using the microdata could presumably use or create, using the demographic variables on the survey, even better weights than what we deliver with the data, right? So this is just the first cut on what we do so that the data are somewhat better representation. I should also mention, though, that it isn't our goal to have here the perfect sample to represent at a given day globally the population, of the US population. The true strength of this data collection is that it can happen on a small geographic level daily, so that we can see changes over time. So even if the Facebook user base is a little different than the actual population, we assume that whether you encounter COVID and many of the related activities are not related to your participation in Facebook, and anyone in a community who is on Facebook can be a good representation of that community for a given day in time to make these data very valuable in its longitudinal fashion. Next slide. So let me show you the vaccine questions that Alex is going to present results for in a moment. There's a whole series, and many of them have follow-up questions and detailed subgroups, but the main ones that we focus on here were initially vaccine acceptance along the line of, if a vaccine to prevent COVID-19 were offered to you today, would you choose to get vaccinated? Or which of the following, if any, are reasons that you definitely wouldn't choose to get the COVID-19 vaccine? And what you see there in italics is the different answer category that was given at the previous question, and then it's just filled in here. Or questions, and that was in particular of interest for WHO, did you experience any barriers for getting COVID-19 vaccine, and concerns about side effects or anything else when getting vaccinated? Next slide. So Alex is going to take over from here on, and we'll start off with the few face validity, how good are the data slides, and then dive into the results for these vaccine questions.
All right, thanks. Yeah, let's start with some face validity questions. So the first thing you might ask about a survey of this scale conducted in this way is, if you're surveying people on Facebook, are you really getting any useful signal at all? What can you learn from a survey like this? So before we get into the vaccine questions, I'm going to get into a couple examples of how we know that the Facebook is measuring useful signals. For instance, this example comes from the United States. Along the top here are 4 major cities. This is last summer, from June to August last summer. You remember in the United States last summer, there were some big case increases. On the top there, we have the percentage of survey respondents in those cities who reported that they know someone who's currently sick with a fever or cough, things that look like COVID-related symptoms. On the bottom are the official case reports from state governments, health agencies, and so on for those same cities. And what we see is, first of all, the survey tracks the official reporting quite well. The increases in cases are reflected by survey increases. And second, there's even an advantage here. So official reporting is often subject to certain problems. So for instance, in San Antonio, you see quite a strange spike. That's because on one day in San Antonio, the government had to backfill, meaning report all at once, like 5,000 cases that actually occurred in previous weeks, but due to a bureaucratic problem, getting things tested and reported, they all got reported on one day. This is a 7-day average, so suddenly we see this big 7-day lump in the data. They never provided the actual dates of those cases, so there was never you can't correct backwards to fix this issue. But the survey data, being from a survey that runs continuously, is not subject to the same type of problem and provides a sort of external reference. Similarly, with the international survey, there are many countries where case reporting is perhaps not as reliable or convenient as case reporting in the United States. And if we look internationally, here are 3 countries worldwide. And here we've plotted in black the official case reporting for those countries. So, COVID cases per day in those countries, and in red, slightly different question. So this is a question that's available on both surveys about the percentage of respondents who say that they are worried about their household's finances for the next month. And we see a strong relationship between increases in cases and increases in people's concerns about their finances, for instance. And so that, suggests both the survey is measuring something real and it potentially has policy implications for, government reactions to the pandemic, what they do when their case rises, and so on. So next, now that we've established that we're at least measuring something, let's talk about what we're measuring related to COVID vaccination. So we've been asking in both surveys about COVID vaccinations, the questions that Frauke mentioned, since essentially the beginning of 2021, basically right at the beginning of January. For instance, here we see vaccine acceptance worldwide in late January 2021 of this year. So this was the question that you saw earlier, asking if you were offered a COVID vaccine today, would you choose to get it? And we see COVID vaccine acceptance varying quite widely in countries around the world. The Americas showing quite high vaccine acceptance, places like Russia, Kazakhstan showing much lower vaccine acceptance. The US is in gray here because, as we mentioned earlier, the US data and the international data are collected separately, so it didn't end up in this plot. But I'll be showing some of the US results to you momentarily. We can track, one of the advantages, as Frauke mentioned, of this survey is that it runs every day with a new sample of respondents recruited daily. And so you can track trends over time and geographically. So for instance, here are 5 relatively populous countries. And here is vaccine acceptance in those countries over time, where we define acceptance here to mean either they say they would get vaccinated if offered, or they already are vaccinated. And presumably people who are already vaccinated are vaccine accepted. And we see the rates in all of these countries increasing over time. And you might notice, by the way, these are the confidence intervals plotted on here. They're narrow because this survey is big and this is aggregated monthly here. So you can see the sort of, you begin to see the advantages of a survey of this scale. Similarly, not only can you break down by location, but for instance, this is vaccine acceptance in the United States measured the same way, but broken down by race and ethnicity. And we can track those over time. This plot here is actually weekly rather than monthly. And you can track vaccine acceptance week by week in 2021 by the different racial groups. You can see the disparities. And most interestingly, I think, to highlight in this plot, is the trajectory of this line here, which is Black or African American respondents, going from less than 60% vaccine acceptance near the beginning of January to nearly 90% vaccine acceptance by late May. It's like a 25 or 28 percentage point increase in vaccine acceptance in this group, which is incredible. There's many mechanisms happening here. But there have been targeted campaigns directed to this group. Also, I think acceptance has been increasing generally as more people get vaccinated and see their friends get vaccinated and so on. But through the survey, we're able to track that. Similarly, worldwide, an interesting trend one can track. On the left here, we see vaccine acceptance in various regions around the world in January. And here split up by gender of the respondents. And you notice that the women tended to have lower vaccine acceptance than men in many of these countries, in many of these regions worldwide. On the right, on the other hand, we have that same plot made again for April. And many of the disparities have actually closed. This is interesting and notable, both because it may suggest, like in January, it might suggest which groups you need to target to increase vaccination, but also because it's actually the opposite of what many people I spoke to expected. Men tend to be worse than women in many health measures, life expectancy, compliance with various things. So it's a little unusual to see it reversed here and men be more accepting of vaccinations early on. I'm not quite sure why that happened, but it appears much of that gap is closed in the 3 or 4 months that we were tracking here. I've also mentioned, the advantage of the survey being that you can focus in on local areas. So here we have Germany, we've split up by region. You can track vaccine acceptance. This is in early January by, I think this is administrative region 1. So And you can track that over time since the questions were added to the survey here on the right for each of those regions. And you can extend this out, until a few days ago as we compile the data if you want. In the United States, similarly, we collect zip code from respondents. So we are able to code responses down to the county level. I haven't shown a map here, but one can do a similar map in the United States at the county level. And I'll just mention some collaborators of ours, Josh Salomon, Marissa Reitzma, and some of their group at Stanford University have been working on doing essentially a post-stratification approach to use county demographic features and the survey data to build a county level national vaccine acceptance map that could be potentially used for policy decisions. Where do we direct advertising? Where do we direct our vaccination campaigns? We're actively working with various government teams to try to get that information in their hands. So if you were to do that, if one was able to provide this information, vaccine acceptance information from the survey to the CDC or the World Health Organization and so on, what could they do with it? How could you enact a change to increase COVID vaccination around the world? Well, I mean, it's hard in a survey to ask people, please tell us how we could change your mind. People don't tend to answer questions like that in thoughtful ways, but we did get at some useful information in the survey. For instance, one question that we had for a while in the survey was to ask respondents who said that they wouldn't get vaccinated or they only probably would get vaccinated, would you be more likely to get vaccinated if it were recommended to you by any one of these groups? Politicians, your friends or family, government health officials, the doctor or local healthcare workers you go to, the World Health Organization. And then we can see here what percentage of people say that they would be more likely to get vaccinated. Each of those groups recommended it to them. And here we've stratified by, this is in the international survey instrument, stratified by whether the COVID vaccine was available at the time this was collected in those countries. This was in mid-January. What we see here is something that might suggest which groups should be out delivering the message. So for instance, local healthcare workers are typically, according to this data, more trusted than, for instance, politicians. The World Health Organization was more trusted worldwide. I can tell you that in the United States, the disparities between groups here are somewhat larger in that I think, if I recall correctly, something like 2% of people said politicians would make them more likely to get vaccinated. I think the World Health Organization didn't rate quite as high in the US, but local healthcare workers consistently showed as a strong, those, if anyone were to convince me, they would be the people to convince a hesitant respondent to get vaccinated. And so, one could in principle break this down further by all the demographic variables, geography, things we've shown earlier. So if you were targeting a campaign, you could work from this kind of information. Another question that you might ask if you're trying to target a COVID vaccine campaign is, why don't people want to get vaccinated? And so we provide a selection of responses for people who say that they wouldn't get vaccinated. Well, why not? And so on the left here, we first see a comparison of some countries worldwide of vaccine hesitancy between men and women. I think highlighted here is Central Europe, Eastern Europe, Central Asia. You see the scatter plot there comparing men and women. And seeing women being, I think here, actually a little more accepting in that group. Or no, this is rejecting, sorry. So the reverse, they'd be more likely to reject the vaccine. Like we were discussing earlier. On the right, we see the reasons that the respondents selected, broken down by region. And so for instance, this column here is respondents who selected as one of their reasons that one of the reasons they wouldn't get vaccinated is they're concerned about the side effects of the vaccine. And most regions around the world, more than half of hesitant respondents say that. Similarly, in most regions around the world, more than half of hesitant respondents say that they'd like to wait and see if the vaccine is safe. In fact, often this is the same respondent saying both of these things. We'll see that in a moment in the US. Some percentage of respondents are worried about efficacy. There's a smaller group that's worried because they don't like vaccines. It's actually a fairly notable group here labeled altruist, which is people saying, well, I don't want to get vaccinated now because other people need it more than I do. So they're not opposed to vaccines, they're just opposed to getting them before everyone else. You see, for instance, cost showing up as a fairly small, less common response. So this is quite interesting. This suggests if you were to do messaging, well, what messages do you need to give people? In this case, it looks like safety is an important point to emphasize. And if I can go a little further, here in the United States, we can break down reasons. These are vaccine hesitancy reasons reported in May in the United States. And this is called an upset plot. It'll take a moment to get oriented with this plot. So each column here, this question gave people reasons, and they could select any combination of reasons. So you could check 1 box, 7 boxes, however many boxes apply. So for instance, we pick one column here. This column has, I don't need the vaccine, I don't trust the government, and I'm concerned about side effects filled in. So this represents that about 1% of respondents who are hesitant in the United States selected those 3 reasons and no others. So this is a unique combination, 3 reasons that occurred about 1% of the time in hesitant respondents. If we look at this plot, we can see the most common reasons besides other are people saying they want to wait and see, saying that they don't think they need the vaccine, or saying that they don't trust the government, followed by side effects. And then we start seeing combinations. There's a fairly large group of people who select both, I'm worried about side effects and I want to wait and see, or select both, I don't trust the government and I don't trust vaccines, or combinations of these. And if we start reading the rows of this, we start seeing there's sort of 2 common themes. The people concerned about safety and the people who don't trust the government or don't trust vaccines or otherwise don't, perhaps don't believe that the pandemic is real or have trust concerns, conspiratorial concerns, perhaps. Finally, to talk about messaging, I'll mention one other thing, which is for unvaccinated people, what's stopping them from getting vaccinated? So this is the same kind of plot. And here, this is based on one of the questions Frauke mentioned some time ago about what barriers have you faced to getting vaccinated? And we asked that both the people who are already vaccinated, what barriers did you face getting vaccinated when you did? And the people who are not vaccinated, what barriers are you facing now to getting vaccinated? So we've split this up on top here as people who are not yet vaccinated. You can see that among people who are not yet vaccinated, the most common barrier they face is actually, well, I haven't tried yet, which is a little concerning, followed by reasons about, well, there weren't appointments, or I can't get time off of work, or combinations, things like I can't get time off of work, the times available didn't work for me. I can't get time off of work, there weren't appointments. I can't travel to the vaccine site and there weren't appointments. Suggesting that besides the sort of perhaps group that doesn't feel a need to go out and get vaccinated right now, they haven't tried, another big group is people for whom it's simply not convenient enough. Maybe there's a group that they can't get time off work. We see childcare show up here, although less common. I can't travel. For basically getting to a vaccine site would be expensive because they have to lose hourly pay, for instance, or difficult or inconvenient. So they're not doing it. Among vaccinated respondents, you see the biggest barrier was just there weren't vaccines. Of course, vaccinated respondents are the ones who probably got vaccinated earlier in the pandemic, earlier in the availability of vaccines, back when supply was quite limited, and they persevered and succeeded. So having seen those insights, I think I'll just mention that we are talking to groups like the World Health Organization, the CDC, the White House's COVID response team to share exactly this information with them so they can use it to make decisions about vaccination campaigns. But for now, I think we'll turn it back over to Frauke to talk about data access, getting access to this data, and then some challenges that we faced in fielding the survey.
All right, thanks. Yeah, so very briefly, the 2 arms are accessible via APIs and contingency tables. So, pre-populated tables on a combination of variables. for the global data on the covidmap.umd.edu website, and for the US survey data on the CMU Delphi GitHub IO, the full link you see here. There is the possibility to access the non-aggregated data for research purposes. And to do so, you can contact the Facebook Data for Good to sign a data use agreement and then proceed from there. It's with most institutions a pretty easy process, and we have now over 80 institutions, I believe, that use the data. So all the lawyers are quite practiced in signing these agreements. Next slide. We should also mention, some of you might have heard or seen the COVID-19 Preventive Health Survey that was run in a partnership between MIT and Johns Hopkins University. Since wave 11, we basically combined these two survey efforts and included some of the questions in the COVID-19 Tracker and Impact Survey that we just introduced here. So they're not longer two distinct sets, but there are other data for good surveys that Facebook does on the platform. The Future of Business Survey in collaboration with the World Bank is one of them. Next slide. And we also want to make sure you have a few links to additional complementary data sources that are available through the Delphi COVIDcast Epidata API. I recommend spending some time on that website, but also Facebook's Data for Good website has information that they take from the user base, not individual posted data, but sort of network connections and movement data of that sort. So that's an interesting other data source. If you have any questions to that, you should feel free to reach out to us. I'm looking at Ryan here in terms of timing. We have a roughly 5 more minutes and sort of challenges in running this server globally, but we can also come back to that after some initial questions. You can tell us.
I think it makes sense for you guys to continue on.
Okay, great. Next slide, Alex. I wouldn't be a methodologist if I wouldn't add a few challenges of that sort. And I'm not sure if Alex or Ryan, when they started this, but certainly for me, it was true that I very naively thought, well, I've done surveys before, sure, I can host those global data. And if you move to the next slide, Alex, if you think of any data science project, and since this is a data science webinar series, we thought we'd throw this back in, I mean, you might find yourself in one of those 5 buckets and as being your primary wheelhouse on skills. In my case, certainly the data generating process and, data analysis. We did have to find very quickly at the University of Maryland an additional team in geography to manage the large curation and storage of the data. I mean, this was these millions of responses and getting so many responses and updates daily, that was way more than we've ever handled, and running analyses on those is really not trivial. And but one piece that I would say, shame on us for not thinking ahead, was really this last part on data output and access, right? I mean, we were good on syncing with WHO and the World Bank on getting the research questions and the survey questions right, but making sure that we work early on with teams who sort of push out the results, that I think we lacked a little bit. And luckily there were other collaborators from Boston Children's Hospital and some other groups that I'll mention in a moment that helped on that front. But if you plan on doing something of that scale, I recommend thinking ahead with those kind of pieces, because there's a lot of work in collecting the data, and it's a shame if no one knows they exist. Next slide, please. There were some other challenges too, just in terms of global scale. This had to start so quickly in so many languages that we could impossibly do a proper pre-test or pilot test on how this all works. So, we're now in wave 11, every time we make changes to the questionnaire, there's sort of a little bit of a nervousness and the possibility of breakdowns, which most recently in wave 11, we actually did see happening. But also other things, you have to imagine many people answer these surveys these days on mobile devices. Actually, the vast majority does that. And the way it's displayed on the mobile device might not be how you planned it on a website or what have you. And early on, for example, we made the mistakes on the global survey that my email address for contact was a hot link, and people were accidentally hitting my email instead of the next button, and so I got a lot of emails, people telling me how they feel about COVID and what happened, and in all languages. And thanks to Google Translate, I could sort of figure out what's going on here. But it was really like thousands of emails within a few days. So that we fixed that quickly. But those are things that happen when you do these at scale, and in our case at Facebook speed. Very little time to check certain things. Next slide, please. I should warn anyone looking at the data or on this being transparent here. Wave 11 was one of those things where we really saw jumps in the data. You see on the right here the timeline on vaccine side effect hesitancy. All in a sudden, a huge spike. And as always, when you analyze data, there's a gigantic effect. It's likely going to be something messing up with the data processing, and that was the case here too. Reversed pretty quickly. In Brazil, we had a little, anxiety occurring because the COVID symptoms. We had changed the order in which we ask about the symptoms and whether people have any symptoms. We had adopted to the US instrument, which first asked if someone in the community is known to have COVID, and then about the personal symptoms, and a known hindsight is 2020, but in survey methodology, not unusual to see order effects of questions. And again, it is a good tale here that these things are much less about point estimates, but about trends over time. And then obviously, if you do modernizations to the instrument, you always have to make sure you don't break the trend. So in this case, we had a random sample of 20% that got still the old version, and we could quickly see this was just a questionnaire effect, and then reward what we needed to do to not break the analysis of those using the data. Next slide, please. So for that reason, if you plan on using the data, do look at what's new and sign up to our mailing list to get informed about changes in the instrument. That will, at least make sure that you know this. Next slide. And, a shout out on our collaborators that have been from early on using the data and creating big impact with it. Next slide. Among the first was IHME. They couldn't find any other data source in their many trend reporting efforts on mask usage and mask wearing. And so they used the international and the US data heavily to fold that into their model. Another interesting example, next slide, is coming out of Johns Hopkins. We eventually added on the US survey questions about schooling, and Justin Lessler and his team, including Elizabeth Stewart from Johns Hopkins, co-organizer here, just got a paper published in Science using these data. So that was pretty exciting for us. These mental health questions that Liz Stewart created, they also are actually an interesting last validity check. Alex, if you want to show that graph. Oh, parts of that slide didn't load. Okay, well, that's going to be a cliffhanger till the end. So we have this question on anxiety, and track that over time. The good news, we are, early in spring, we saw the anxiety among our respondents go all the way down, and it's looking even better now. You might wonder about the two spikes, but if you look closely, you will see this is the US election, and then the events around January 6th. So, relative to other events happening in the US, anxiety levels not changing all that much with the pandemic, which was pretty good news. But the best news, as I said, that they are going way down now as we are hopefully inching out of it. So this said, thank you all. And Alex, if you want to throw up the last slide here, feel free to ask questions now or reach out to either the entire COVID-19 symptom survey team or us personally at our email addresses. Thank you.
Thank you, guys. That was a wonderful talk. Super interesting. I'm going to start asking some questions. I would like to encourage folks to put questions in the chat or in the Q&A if they have them. Actually, you know what? I can already start with a question from the chat because it just got put in there. So Patricia asks, you mentioned the new sample size was selected daily. What was the sample size per day?
Alex, maybe you start talking about that for the US. That's a little easier number to recall.
Yeah, so in the United States, the sample size, if you average over the entire length of the survey, it was about 50,000 respondents per day since April 6th, 2020. It started a little higher, it's now a little lower, but 50,000 or so is about the rough average.
Yeah, and internationally, it depends a little bit on the country and the population, the Facebook penetration in the countries. In Germany, we have about 1,000 respondents, 1,500 respondents a day. And then certainly weekly, plenty in each of the regions. But the sampling rate in the US was purposefully higher because we tried to design it in a way that you can have county level estimates and can make, small, insights on a smaller geographic region. But still, I guess, 50,000 and 1,000 a day, those are both pretty high numbers compared to what we see in other data collections. Now, mind you, size isn't all, right? It is important that this is a probability sample at its base, even so the population is maybe not a random sample of the population.
Thanks, guys. So there's another question that came in from Mark. Mark asks, given your results, what behavioral science or social science theories of cognition or motivation would help in convincing people deciding to get vaccinated?
Yeah, this is a tough question, but a pointed one. So I can say in the United States, I am neither a behavioral nor a social scientist. But in the United States, what we've seen, at least in motivation and in our discussions with the White House, for instance, one big thing seems to simply be ease of access. In other words, it's not so much convincing people that they should get vaccinated and like giving them a reasoned argument or something. It's making it really easy. You saw earlier when I was showing the barriers to access that for many respondents, barriers are getting time off work, finding time that they can go, travel, and so on. We've also seen big disparities by occupational group. So for instance, construction worker is much less vaccinated than any other group or most other groups. So it occurred to us perhaps like work site vaccination campaigns, things like that, where it's just the vaccine's right in front of you. So there's no barrier, you can get it right now. Some of those things may prove to be helpful.
Yeah, I think I can add to that. I was just actually yesterday listening to a talk by two sociologist colleagues here in Germany, and they made a point too in saying that, by and large, there's still luckily a good reason to believe that rational choice, or the related theories do hold. And that speaks to what Alex says. We do see if the information is easily digestible and if the barriers are removed, then the hesitation isn't all that large. We do see though that at least in a lot of countries, or at least in those countries where I can access the language, that the information campaigns or the website where the main information is provided by the government are not necessarily the most easy digestible. And so I think those that try to derail the public have an easier time if their messaging and languaging is easier, so.
Thanks, guys. I'm going to throw in my own question while I wait for others. Again, I encourage you to put questions in the chat or the Q&A if you have them. Can you guys speak a bit more in comparing the survey that is still running and that was run over, since last April, to other efforts that maybe were similar in the over the course of the pandemic and also pre-pandemic? So in what ways is this survey similar to what we have access to elsewhere, and what ways was it different? So
maybe I'll start off with one thing that I noticed early on in terms of attempts to create this symptom surveillance, we saw very quickly at the pandemic, at the start of the pandemic, a lot of websites pop up with the invitation for people to come visit and tell how they're doing, and say where they live, and a couple of covariates about them. And the problem with those is that there's no probability base around it. You have no idea if it's the same person accessing that website 20 times in a row or 2,000 times in a row, or if if it is a nerdy internet population which happened to visit the MIT website or what have you, right? I mean, not actually pointing to particular institutions, but those very entirely volunteer surveys without a known selection mechanism, they appeared a lot at the beginning, and this was an attempt to create fine-grained data on a a good timely scale and geographic scale that doesn't suffer from that part. So unlike these advertisement survey that I mentioned, this one here, a Facebook user can't recommend to his or her friend to also fill out the survey, right? It's you're selected. If you choose not to do it, you're non-respondent, but it's not that someone else could fill this in for you in that sense.
I'll also mention one interesting effort that's occurred. There's a number of health-related apps that have encouraged their users to, every day report how you feel. Do you have symptoms? If they test positive or something, report on that. And those suffer from similar problems of being not a probability sample. They're people who happen to be users of this particular app for whatever reason. But they have the advantage of being able to track the same respondent over time. So if the respondent says, I tested positive, well, they can ask them tomorrow, well, how do you feel now? And follow up with them. So you get one advantage of this cross-sectional or sort of longitudinal tracking of the respondents, but you don't necessarily know about the bias in your sample or in your user base. And those have been used to produce some interesting results. There are a couple of groups that have large data sets like that. And if you have the right questions, you actually can use that data to answer it. So those work well, but they sort of get at different questions than a survey like ours can.
And thank you, Alex, for mentioning that. In particular, the UK were fantastic in having those data available. And I think, we saw, very high profile papers coming out of it. It goes back to that one slide that I showed about the data science process, right? It really, what type of data is useful for you for a particular research question is really a function of what that question is, right? It would be foolish to dismiss one source, offhand, but it's also not a good strategy to think a certain type of data could be useful for all research questions.
Continuing on, I'll just ask another question. A large part of the motivation for the survey, as you guys alluded to, and certainly this was on my mind, in the early weeks, was that the survey would be able to provide syndromic surveillance in some, dream scenario. For example, we would see an uptick in self-reported symptoms or reported symptoms in the community early enough that would actually be actionable information for the public health response. So it would be earlier than, let's say, what we see in confirmed cases, which have inherent delays due to, a variety of reasons, but the public health reporting system is not something that, is an internet survey. So of course, it can't function the same way. I'm wondering if you can now look back over a year later and comment on what you see as the biggest value that the survey has provided and will provide in terms of the data that it's produced in the years to come, and whether your perspectives, and of course they can be different because you guys are different people and they're certainly different than mine as well, as to the values of the survey have changed over the last year and several months.
Yeah, maybe I can start this off. So I think we all got motivated by the argument that you just brought, you know, that wouldn't it be cool if that happens? And this goes to, you know, shame on us, I think, for not making sure enough people really, like, you know, this disconnect on enough people really knowing this is now available as a resource, but also maybe some distrust if this is really good enough data, right? This is the first time something was done like this on a global scale. And I think we all had to learn that, yes, indeed, these are valuable trends and signals that we pick up here. We did have a data analysis challenge last fall, I believe. And there was a team from Brazil who really showed the value of these data, and that, you know, had one paid close enough attention, they could have 2 weeks earlier started the lockdown and saved a lot of lives that way. And I do think that that has really increased the user base there. That's why they were up in arms when in wave 11, all of a sudden we saw that uptick. And, you know, luckily this time it was an instrument change that resulted that, and we resolved that pretty quickly. But, you know, it's not entirely over yet. And I think that those places very much monitor this. And it will be useful come the fall, or come variants of the virus that might cause this again. So I think it does provide continued use. The other big thing we've seen, it because of its fine time scale, I think for years to come will be interesting to sort of look at the effectiveness of certain measures. And, you know, subgroups where behavioral changes happen faster, slower changes in, you know, symptoms and the like.
Yeah, I agree, particularly with that latter part, that a lot of, I think, the interest, you know, the United States, so I'm speaking for the position to mostly looking at the United States survey data, given the vaccination campaign and the state of the pandemic, it doesn't, and the state of the public health reporting system in the US, which despite its many flaws, does at least report reasonably quickly on most COVID cases, that in the US, it doesn't seem like the long-term value of this data will be primarily in the symptoms, but in how did people react when cases increase. We asked about social distancing, their activities and travel and so on. Which of those measures seem to change public behavior the most? How did people react? And, you know, how did people react to vaccinations? How did people's behavior change? What were the barriers to vaccination? Because those are all questions that I imagine people will be studying quite a lot in coming years as they study how could we have reacted better to this pandemic, and how could we react better to the next one, and be prepared for it. I think I'll also mention on behalf of Frauke that one advantage of this data, so she mentioned, for instance, tracking into the fall worldwide. So in the US, you know, we have this advantage of having lots of vaccines. Many countries worldwide are not in that position right now. And so we can expect there to continue to be cases for a while. And they may or may not have public health reporting systems that work as well as the United States. And so having these alternate sources of data, like the symptom data, will still be useful there for some months to come.
Fantastic. I think we're right at the end. So I guess I will maybe have you guys repeat one more time where people can access the data. Maybe you can flash the slide up, and I'll let you guys, you know, give maybe one or two encouraging sentences about the fact that there really is still stuff to do. It's not like we figure everything else out, and then we'll sign off.
Yeah, lots of it. And in fact, I mean, we really welcome and embrace anyone who wants to do analyses with the data. There is like way more. It's not that we have first dibs on the data. You know, we really want you to just take the data, have an idea, look at it, run with it. And also, if you do feel like as things change, there is a question that really should be on the survey. There will be a wave 12 for sure. And we, in particular, Alex runs these groups that surveys the users on their needs. So this is an invitation for all of you to participate.
Yeah. Yeah, I mean, we have a huge number of groups with data use agreements already, and we would like you to be among them. And it's an interesting dynamic where we have all this data and we would like all of you to have it too. Especially, this survey, we've presented a few items from it, but there are like 30 or 40 questions on the survey instruments, probably more now that with the latest revisions. So there are a lot of research questions you could ask: mental health, symptoms, economics, occupation. There's basically, this town is big enough for everyone. This is an old Western, so we would like to see all of you join and study your own interests in this data.
The opposite of the applied statistics problem. Instead of, we have all these tools, give us the data, it's exactly the opposite. So I want to thank you guys again, and thank you everybody for attending and for some good questions, and we will see you next time.